we have certainly come a long way. What I mean by that is, about 15 years ago, when you would have anything dealing with aesthetics, there literally used to be 3 or 4 people in the hall. But today, if there are 3 or 4 people in the hall, they are for ophthalmic and facial cosmetic surgery. So clearly, we've come a long way. Uh, this course was also submitted to the APAO 2 years ago and never got accepted. So it means that there are people who are seeing interest in this. It takes time for a movement to occur. And here we are talking about facial cosmetic surgery. So without further ado, it's my privilege, honor to introduce one of my best friends at the APSO PRS. Hoseok Sa is one of the nicest people I know. And I hope all of you will fall back upon him to teach you all the wonderful things he knows. He's trained a whole generation of Korean ophthalmologists and oculoplastic surgeons, and he's also the vice president and the ex-secretary of the APSO PRS. Hoseok, over to you.
Thank you for the kind introduction, and good morning, everyone. It's my honor to be here, and I really want to appreciate to Dr. Deborah Shon for organizing this wonderful session and inviting me. My topic today is upper eyelid blepharoplasty and Asian blepharoplasty. There are many ethnic groups around the world, as you know, and only within the Asia, so we have 6 different ethnic groups. And in my talks on Asian blepharoplasty today, so Asia will refer to East Asia, so please understand this fact. Asian eyelids has a very distinctive appearance because of the differences in eyelid crease, epicensal fold, and fat pads. Many Asian eyelids, they don't have any eyelid crease, and even when present, the height of the eyelid crease is much lower than that of Caucasians one. It's usually because of the lower fusion point between levator aponeurosis and skin dermis. Epicensal fold is another feature of Asian eyelid, and epicanthus tarsalis is the most common type. And when the patient has a prominent epicensal fold, it can make a delusion of ptosis like this, and many young Asians want to remove this. And Asian eyelids contains more subcutaneous and subovicularis fat with the component of the pretarsal fat, so which can make more puffy appearance in Asian eyelids and also interfere the presence of eyelid crease. So these Korean actresses have beautiful eyes with eyelid crease, but you can see these celebrities also have attractive eyes without eyelid crease. So in East Asian beauty standard, the beautiful eye can be described as the large palpebral fissure in width and height, regardless of presence of eyelid crease. So Asian blepharoplasty, the goal of it is to make a large palpebral fissure by use of double eyelid surgery or medial epicanthaloplasty. Asian blepharoplasty can be categorized into double eyelid surgery and medial epicanthaloplasty, and double eyelid surgery can be categorized into suture method and incisional technique. Non-incisional suture technique is a very simple procedure which can provide more natural appearance, but the eyelid crease can be less permanent, and this technique cannot remove excessive skin or fat. This is the downside of this technique. So good indication for this technique would be younger patients with thin and non-redundant skin, with little preoperative fat or orbicular bulk, and crease easily formed with marking as shown in these photos. And there are various techniques based on the step incision and suture number of stitches and suture types. And single continuous suture method is my preferred technique. I use this technique for almost all patients. When it comes to the design, so you can put 3 points along the natural extension of the medial epicensal fold. After that, local injection is performed to conjunctiva and skin. And using 11 blade, you can make a step incision at 3 points. And 7/0 nylon suture is passed through the step incision to the conjunctiva just above the tarsus, and get back to step incision and move to another next step incision. And you can repeat the full thickness suture like this. And this can create the 3 full thickness loops of suture at the superior margin of the tarsus, which can make a skin fold. And after that, the suture is passed through the lateral step incision. And you can make a note, which is buried in the step incision. And this young lady underwent a single continuous suture double eyelid surgery. As you can see, so she have a very thin natural appearance, natural looking eyelid crease, which is preferred by most East Asians. And here are some other cases of single continuous suture method. And it's not uncommon for young men to seek for double eyelid surgery in Asia. And moving on to incisional technique, good indication could include the patients with redundant skin, excessive fat tissue, blepharoptosis, or eyelid with scar, because this technique can address this kind everything. Small incision technique is less invasive procedure compared to full incision technique. And in this method, skin incision is made 8 to 10 millimeter wide at 6 to 8 millimeter above the lid margin, which can allow fat removal or liveator aponeurosis advancement at the same time. And 7/0 nylon suture is used to secure the subcutaneous tissue, tarsus, and liveator aponeurosis to make a double eyelid crease. Here are some cases of small incision technique. And incision technique can create a more stable eyelid crease. And as I said, the soft tissue manipulation can be performed simultaneously, such as resection of skin, fat, or orbicularis. This is more traditional type of blepharoplasty. And in Asian eyelid, the lid crease height is recommended 6 to 8 millimeter for female and 5 to 7 millimeter for male. And it's important not to make too much fat because it can cause the unnatural sunken eye as shown here. And these are some cases of incision blepharoplasty. And my last topic is a medial epicensoplasty. So in Asian individuals with an epicensal fold, the preseptal orbicularis muscle run through the medial epicensal tendon to cover the medial epicensal tendon. And histologically, the medial epicensal fold is composed of outer skin and fibromuscular core band. So the goal of medial epicensoplasty is releasing the vertical tension by removing or cutting the fibromuscular band and repositioning of the outer skin using various flap techniques. So indications for medial epicensoplasty include prominent epicensal fold that cause cosmetic and functional problems, and patients with prominent epicensal fold undergoing double eyelid surgery. If the double eyelid surgery is performed without epicensoplasty, it can result in this kind of unnatural semilunar fold in the medial side. So in those kind of patients, we have to perform epicensoplasty together with double eyelid surgery. So techniques can be categorized into transpositional flap and advancement flap technique. And skin redraping method is popular in South Korea. And I use my own modified technique, which is a modified version of skin redraping method. And in this technique, the incision is extended to the upper eyelid, not to lower lid, and merges with the blepharoplasty incision. There is no need to make a flap on the lower lid, and the scarring is minimal in this technique. In this technique, new canthus is marked, and original canthus is marked, and incision line is drawn between two marks. And we have to perform incisional blepharoplasty at the same time, so incisional blepharoplasty design is made. So you can see the lid crease height is very, very low compared to other ethnic groups. After injection, the incision is performed between 2 points, and I'm removing the fibromuscular core band to soften the medial epicantha fold. And blepharoplasty incision is made. And some amount of skin and orbicularis muscle is removed. And the dog ear on the lower lid is corrected. And we can do additional resection of fibromuscular core band to weaken the medial epicantha fold. The medial canthus formation suture is made using an observable suture such as 6-0 Bicro. And then skin is repaired using a 7-0 nylon, and you can see the lid crease formation suture was also performed. And you can see right after the surgery, you can see the medial epicanthaloplasty was performed naturally. So these are some cases of modified skin redraping method performed together with incisional blepharoplasty, and the scar is not that big. The scar is minimal. So in conclusion, Asian blepharoplasty is to make a larger eyelid, retaining the patient's Asian ethnicities, not making westernized eyelid. And there are some various different type of method for double eyelid surgery. So it's very important to to choose a proper method for the patients. And medial epicanthaloplasty should be combined in patients with prominent epicantha fold when they undergo the double eyelid surgery. Thank you very much for your attention.
Okay, thank you very much. So say as usual, I have one quick question that if you have doing the double eyelid surgery with suture method, do you prefer to do the same incisional like medial canthoplasty simultaneously, or you leave it after?
Yeah. It's a great question. So I always do epicanthaloplasty. When I have to do epicanthaloplasty, I prefer incisional technique. Okay. Because in those patients with the prominent epicantha fold, there is a good chance to loosen the double eyelid even after the suture method of double eyelid surgery because of the epicantha fold. Even after we remove or weaken the medial canthal fold, so incisional technique would be better or beneficial to make a more stable eyelid crease. So that's why I use incisional technique for that kind of situation.
Okay. Thank you very much.
So thank you for the wonderful presentation. So I have a little one query. So in patients with a bulky orbicularis, as you have mentioned, so even though we do a very good surgery, so with the patients with bulky orbicularis, in few patients, how much ever orbicularis we remove, still that bulkiness or the elevation would be there. So what is your take on that, and are there any tips and tricks for those patients with bulky orbicularis?
Yeah, it's another good question. So I usually pinch the eyelid before choosing the proper method for the patients. When you pinch the eyelid, in case of patients with bulky orbicularis muscle, you can feel the skin is very thick. So in that case, so I don't use suture method because there is a good chance to losing the double eyelid. And as you mentioned, during the incisional blepharoplasty for patients with bulky orbicularis muscle, I try to remove some amount of orbicularis muscle, especially under the skin incision line. So when you don't remove the orbicularis muscle just near the lid margin, so after the surgery, so you can make some sausage-like appearance. Even though we can make a stable lid crease, the patient's eyelid look like a sausage, so they don't prefer that kind of appearance. So it's important to notice the patient has a bulky orbicularis muscle, and in that case, you have to pay attention to remove enough amount of orbicularis, especially the lower side. That's what I think. Thank you.
Okay, thank you very much, Dr. Jose. Let's move on to the next one. By the way, my name is Masashi Mimura from Osaka, Japan. I'm presenting from my country. And I would like to introduce our big man, Professor Deborah Shomei, as a chairperson of this mission. Of course, everyone knows that Professor Deborah Shomei is being a global pioneer of new techniques and cosmetic surgery. So we are looking forward to have a great section. This title should be, why should you learn facial cosmetic surgery and how to get trained and upgraded?
Thank you so much, Masashi, and thanks to all the friends who are on the panel to be here, and thanks to the audience as well for bearing with us for the past 4 days and still being here early in the morning. My name is Debraj Shom, and a long time ago when I decided to get into ophthalmology, because I saw that as a route to get into facial cosmetic surgery, a lot of people wondered why ophthalmology should be the residency route to get into facial cosmetic surgery. But the truth of the matter is, when you train in facial plastics and facial cosmetic surgery, majority of the folks who are doing facial plastics and facial cosmetic surgery today come from either an ophthalmology or ENT background, at least in the Western world. So I was a very odd ophthalmology resident who never wanted to do cataract surgery. I was very certain I was not interested in cataracts. I would never do cataracts. And for me, my ophthalmology residency was a way to get into facial cosmetic surgery. And today, approximately about 12 to 15 years later, when I see that facial cosmetic surgery is one of the instruction courses at AIOS, then some of what I felt feels validated and vindicated at this moment in time. It's very important to understand that when I treat the face, the most important parts of the face or the most difficult parts to treat are all periocular. And given the fact that ophthalmologists have had experience in dealing with with microsurgery, it's only fair that ophthalmologists play a major role in facial plastic surgery as it moves onwards and upwards. Our specialties of facial aesthetics and facial cosmetic surgery have not been around for that long. If you think about it, it's only in 1989 that Allergan's Botox received US FDA approval. And obviously, all of us are very proud and know that the use of Botox in facial aesthetics has actually dermatology as well as ophthalmology backgrounds, because Gene Carruthers, one of my mentors, is an oculofacial plastic surgeon based out of Vancouver in British Columbia. Now, we started using, I'm not going to play this video because there's no point, but this video was actually on hemifacial spasm. That's how we started treating things. And then when you saw the lines disappeared, by serendipity, you discovered that it might be a good time to use the Botox for facial lines. And fillers actually came into the market in the early 2000s. So fillers started entering India only around 2005 and 6, 7 maybe. So as a result of which, and that too, they were very low G prime fillers at that moment in time. So actually, it's not even been 2 decades since fillers came in, which is why this particular specialty of the face is still so undecided. Everyone thinks they own it, but no one really understands it, and no residency program really trains you in it. Now, if you want to see patients like this, so if you saw a patient like this, yes, she has under eye dark circles, she's got a little bit of aging and all of that, but just concentrating on the typical oculoplastic treatments of trying to treat her periocularly would not give you results like this. And that is why learning how to treat patients holistically becomes important. No fracture, no treatment actually looks at residential fault lines. They occur all over the face, and therefore you need to learn to treat patients, or we need to learn to treat patients in a manner which makes it holistically possible to generate results such as these, or these. Now, how did it all happen? I think the first and the foremost important thing is to figure out what you really want to do in life. In my opinion, if you want to get into facial cosmetic surgery, possibly doing traditional cataract surgery may actually be a deterrent to you. If you are into cataract surgery and you're into refractive surgery, then there's already so much work for you to do. You may not necessarily want to get into oculoplastics and facial cosmetic surgery. I was very lucky that out of my 4 fellowships, my first fellowship preceptor, Dr. Santosh Honavar, who's also the secretary of AIOS at this moment in time, did not allow us to do any cataracts. That's one of the reasons that I trained under him. I didn't want to do any cataracts. And as his only fellow at that moment, a very busy practice at LV Prasad Eye Institute, I was so well versed in oculoplastic surgery by the time I finished my fellowship, I was literally thinking of doing DCRs with my leg, no jokes. Now, at the end of that, you also need to figure out how to get there in terms of skill, right? You get into ophthalmology, you get into oculofacial plastic surgery, but how do you expand your repertoire? And that's what all the talks in this are all about. My friend Tanuj Nakra will join in from the US as well, and he'll tell you how to get into rhinoplasty and so on and so forth. So exploring legal frameworks and pushing the envelope in the Asian region becomes very important. Now, the first part of knowing what you want is knowing what you don't want. And the first part of realizing this is you cannot be all things to all people. You can't be good at everything you do. So you need to be very clear what you want to do. Now, even in oculoplastics, at least the way it's developing in India, we are all super specialized in different things. I mean, my colleagues, Milind Naik or Mohammad Javed Ali, may be a completely different type of oculofacial plastic surgeon. I'm a totally different type of oculofacial plastic surgeon. So even in our subspecialties, the amount of super specialization and the depth of knowledge that each one of us is getting into is probably making things more and more interesting for patients. I cannot hope to treat retinoblastoma the same way that a LV Prasad Eye Institute or a Center for Sight does. And that's what I mean by saying you can't be all things to all people. And above all, to thy own self be true. What does that mean? We need to be clear what we are good at and do what we are good at and refer other things. Now, if you look at my medical journey, I came in from Grant Medical College, which was one of the topmost medical colleges in India, went to Shankar Netralaya, which is probably the holy grail for ophthalmology residency, did my first fellowship at LV Prasad Eye Institute, went to the University of Utah to train under Dr. Richard L. Anderson under the FICO Fellowship for facial plastic surgery, worked at Tata Memorial Hospital, got an MBA from an Ivy League B school in the US, established the aesthetic clinics, got a maxillofacial surgery fellowship from the AOCMF, and so on and so forth, until I finally got American Board Certified in Facial Cosmetic Surgery. This pathway is something that I've explored. And so I'm going to be talking about how you can explore similar sort of pathways in order to make sure that legally you are well within your rights to do whatever you do. Now, let's look at how things are changing. The ICO curriculum for ophthalmology, very interestingly, is now beginning to talk about all sorts of flaps. It's also beginning to talk about endoscopy for treating DCR. It's beginning to talk about the head and neck in relation to the orbits and the adnexa. So it's very clear. One of our other speakers who's going to speak after me is Dr. Bob Goldberg. And he's been an icon all over. And he keeps saying that oculofacial plastic surgeons should own the entire face right up till the anterior cranial fossa. And that's basically what we are trying to do, right? Each one of us in our own way. Interestingly enough, when you look at the ASOPRIS, the American Society of Ophthalmic Plastic and Reconstructive Surgery, you see it's called oculofacial plastic surgery. When I started talking of ophthalmic and facial plastic surgery, and my business card said this about a decade ago, people would laugh. Today, it's really interesting that everyone's trying to rebrand themselves into facial aesthetics and oculofacial plastic surgery. So I feel vindicated all over again. ASOPRIS website is beginning to say your eyes, your face, and our passion. And the your face has actually come in only in the last 5 years. It used to be your eyes and other stuff. But your eyes, your face, and our passion is what is demonstrating the fact that there's a change which is happening. And interestingly, the website homepage says no one knows your eyes and face like an esophagus surgeon. So that's the interesting part which is moving forward. It's also talking about the exclusivity of the health and the beauty of the eyes and the face, because the eyes reside in the face, and ultimately you need to be able to treat everything holistically. Now, if you look, even the mission, they put the face first before they put the orbital eyelids and the lacrimal system, which again points to a change which is occurring all over the world and globally. And this is in 2019. So you can see that even at 50 years, and now it's 55, so you can see that those changes had begun to occur. It's also important to demarcate between plastic and cosmetic surgery, because in India especially, there will be general plastic surgeons who say that a cosmetic surgeon should not do X, Y, and Z. But you need to understand that cosmetic surgery is very different from plastic surgery. When I do a rhinoplasty and I'm trying to raise the nose by only a millimeter, it's not the same as functionally correcting the nose sometimes. So the type of patient you'll do a blepharoplasty in or a 1 millimeter ptosis in is not the same patient as the one who has a very big ptosis or who's got big eyelid bags, right? So you need to understand that people are different. And the market wants that. If you look at the cosmetic procedures in the US and you look at all the statistics, you can see that these are procedures which are continuously expanding. Even if you were treating only non-surgical procedures, 89% of those amount of patients could have been treated by you. So that's an important part to realize that. And if you look at the number of cosmetic, minimally invasive, as well as other types of procedures, you can say Botox is rising all the time, but so are other procedures. And that's making all the difference, right? Now, the other aspect is medical tourism trends in India. I don't know if everyone in this room is aware, but India is the 5th largest medical tourism destination. And being the 5th largest medical tourism destination in the world, it is a great time to develop cosmetic surgery, because in major parts of the world, on the western side of the planet, cosmetic surgery is not covered by insurance. And so when I do my deep plane facelift and I'm American board certified and I charge 10 less than the American surgeon or one of my colleagues who's based in the US, there's enough reason for people to travel to India and get treated. Interestingly, this sort of dichotomy exists not only in oculofacial plastic surgery, it also occurs in the MCH plastic surgeons. This is an editorial which was published in 2012 by the then president of the Association of Plastic Surgeons of India, where he talks about how MCH plastic surgery residency may not really train people in cosmetic surgery. So the point that I'm trying to make is, if no one's trained at residency level, why are we not doing enough fellowships, and why are our fellowships not training people in doing this better? Now, if you look at the American Academy of Cosmetic Surgery, actually the differentiation started to occur in 1979 when the American Academy of Cosmetic Surgery actually separated itself out from plastic surgery and developed multiple boards, one of which was the esophagus, but there were also other boards which were affiliated to the AACS. So if you look at the major specialties doing cosmetic surgery in the US, it's either ENT, oromaxillofacial surgeons, oculofacial, and dermatology. And AACS also encourages all of its members to be either ABCS, which is the American Board of Cosmetic Surgery, and the American Board of Facial Cosmetic Surgery, to actually start training and becoming members of that and becoming diplomates of that. Increasing super specialization has also meant that now there are different boards, both for the body as well as the facial cosmetic surgery. I'm running out of time, but essentially, if you look at the American Board of Facial Cosmetic Surgery, of which I am a part, you see that the surgical log requirements are extremely detailed. They are all about cosmetic surgery. And if you look at the number of oculoplastic surgeons here, approximately about 15% of the ABFCS diplomates currently all over the world come from an ophthalmology or oculofacial background. And that's the major change. These things will continue to develop. People will continue to ask who can inject Botox, who can inject fillers, who is the one who is really supposed to do all of these things. But I tell you just one thing, at the end of the day, we are here in it for our patients. And if you want to make holistic changes on faces of patients, it's important for us to treat the face as a whole. And that's why I think this course is important. And treating people in facial cosmetic surgery is something that we all need to learn to do. I thank you once again for your kind attention and a very patient hearing.
Thank you very much, Dr. Ram. I have one quick question that I'd like to hear your recommendation for the young ophthalmologist, young plastic surgeon. do you recommend the people who want to learn cosmetic surgery after the functional, getting good at functional procedure or simultaneously?
That's a great question, Masashi. We have a university accredited fellowship which we run here on facial cosmetic surgery. Who comes in for that fellowship? Maxillofacial surgeons, general surgeons, MCH plastic surgeons, oculofacial plastic surgeons, all of them come in. Some of them come in after they've trained in functional oculoplasty. But I have also trained people who've not trained in functional oculoplasty, have come in directly from their residency because they want to learn only the cosmetic part of stuff. The person who wants to learn a cosmetic brow lift may not necessarily want to learn how to do a DCR. Okay. So it depends on what we want to learn and what we want to be good at, in my opinion.
Okay, thank you very much. All right, maybe we should move on to the next speaker. Next speaker will be Pingwan Jalu from Thailand. Her topic is lower blepharoplasty, surf lift and mid face lift. Please study your presentation. Thank you.
Hello, good morning, everyone. Thanks for being here, and thanks, Dr. DeBraccio, for inviting me to speak on this session. So I would say, I mostly do lower blepharoplasty. For the surf lift and mid-face lift, I don't do a lot, but I used to do it when I was a fellow back in the US, but in my current practice, I don't do a lot of that anymore. Just to kind of go back into the history of how I got to perform or learn how to do lower blepharoplasty. I learned it mostly during my 2 years ASOPers fellowship at University of Michigan Kellogg Eye Center under the preceptorship of Dr. Ray Douglas. Even as a fellow, I was in an academic center. It was pretty difficult to find my primary surgeon cases. So a lot of times I was the one assisting Dr. Douglas doing cosmetic surgery because these are paid out of pocket. So it's, the patients usually are pretty demanding and they don't, let the trainees do the surgery. So how did I get better at it? So after I finished my fellowship, I moved to Thailand. I started my academic career full-time and a part-time private practice in a hospital. So it does take time to build a volume for cosmetic surgery, at least 2 to 3 years in my retrospective experience, especially if you're in academia, because you're also responsible for other, functional work as well. But it's possible. I would say that in the end, your functional upper lid surgery patients will eventually ask to get their lower lid backs fixed too, if they're happy with your upper lid results, of course. So nowadays, after 8 years in practice, I usually operate on about 2 to 3 cases of lower bleph per week. So that's, I would say, considerably a good number to keep my skills going. And in my opinion, everyone here already know lower bleph. There are many approaches, many techniques. My preferred techniques do evolve over time. It's not about having one perfect technique. It's actually about having the right set of techniques and knowing when to use which one. So think about it as you are having a surgical toolbox. Like the more tools you master, the more precisely you can work. So surgical approach, incision-wise, transcutaneous, transconjunctival, there's debate on which one is better. Some people prefer only one approach, transconjunctival. That's what I was taught back in the US. And I mostly do transconjunctival when I first started doing it. But then nowadays, I kind of evolved into doing either transcutaneous or transconjunctival, really depending on the patient selection and what the adjunct procedures I wanted to do on that patient. In terms of fat management, you can transpose the fat or excise the fat. Of course, excision is a lot easier than transposition. That's what I told my patients. And a lot of the conventional lower blepharoplasty teaching that's performed by, non-oculoplastic surgeons, usually they just excise the fat, not transposing it. And you can even do a combination of both. And in my hands, usually I prefer transposition with a combination of excision if needed, if they have truly excess fat. And for redundant skin, you can, if you do transcutaneous approach already, you can do excision of the skin. And if you do transconjunctival approach, you can still take out some skin, but using the skin pinch technique. For the adjuncts, if the patient has horizontal lid laxity, I usually give them, first step is orbicularis tightening. Usually the incision doesn't have to be very big, just lateral subciliary incision is good enough. And for most of the patients above 50 years old, I would consider doing that for them because they usually have some inherent horizontal lid laxity. Lateral canthopexy can be performed adjunctively, and if they have really severe horizontal laxity, then sometimes I have to do lateral tarsal strip. For mid-face ptosis, you can add SUF lift and mid-face lift, and in my hands, I feel like it's easier to do these adjuncts with transcutaneous blepharoplasty approach. So it's all about choosing the right technique for the right patient. As you can see, these are all my patients. Four of them come for the same issues, lower lid backs, but I perform different techniques for them. Let's take a look at each case. The first case is a 59-year-old female, complained of left more than right, lower lid backs, had a history of filler to the tear trough 2 years ago. You can see in her problem, she does have prominent, left more than right lower lid fat pads, not much tear trough deformity, and mild lower lid skin rhitis and redundancy given her age of 59, right? So I performed a transcutaneous lower blepharoplasty for her in this case. So I make a subciliary incision, usually 2 to 3 millimeter below the margin, and then use the cautery, or sometimes nowadays I use more of the scissors to cut preceptally. And then I open the septum close to the inferior orbital rim, and then I take out the fat in this case. You can take, depending on where the fat is prominent, you can take fat in that area out. So if she has 3 fat pads being prominent, then I take all of the 3 out until it the same level as the orbital rim, then I stop. You don't want to over-excise because then you can give hollowness to the patient. And you can cut out some skin. I'm very conservative about skin cutting. And I try not to cut too much of the orbicularis because then the patient can have lower lid ectropion or retraction afterwards. Okay, so again, in this case, I try to be pretty conservative because she didn't seem to have severe laxity of the skin. And usually, as I said, if above 50, I usually place this lateral canthopexy or orbicularis tightening suture using a vicryl, usually a 5 or 6-0 vicryl, Burris fashion, and then I close the skin incision in a running fashion with the 7-0 Prolene suture. This first case, this is immediate post-op and at 3 months post-op. So she's pretty happy. Another good candidate for transcutaneous lower left with fat excision, so they need to not have that much of the tear trough deformity, which we'll talk about it in a little bit later. For those with tear trough deformity, you may get suboptimal results. A lot of times they may be happy. I would say majority of them are happy because their fat is taken care of, but their tear trough deformity still is visible here, right? If your patients are very picky, then this could be problematic for you, right? Second case, 28 years old female. She said her backs are worse when she's smiling, but you can also see that her right lower lid back is more prominent than the left. She did have a history of filler about 1 year ago, which she didn't feel like it improved her backs much. So you can see that her problems, there's prominent lower lid fat pads. There's really not much tear trough deformity. There is some, I would say, with a history of filler. Sometimes filler lasts longer than 1 year. And I usually at least wait 1 year before I do lower bleph in these patients. And of course, she's young, not much lid laxity. And going through a transconj is gonna be quite a bit of a traction problem to visualize with her being so young. But you can go either proseptal or retroseptal plane or preseptal plane. Which plane do I usually choose? If I do a fat excision transconjunctivally, I usually go retroseptal plane because it just go right into the fat, right? And the septum is not violated. But if I do a transposition technique, which we'll talk about, I usually keep the orbicularis, in front of me, and I go preseptal plane, and then I try to release the orbitomalar ligament first before I cut open the septum and release the fat out, so that is not in my way. Okay, this is my transconjunctival fat excision technique. I open up the inferior to tarsus border about 4 millimeter, and then kind of go right into the fat. I usually give myself a little bit of a traction suture with a vicryl, and then I just take out the fat kind of similarly to what I do for transcutaneous. So this is her post-op results. She is very happy. Of course, you can see that there's still a little bit of a tear trough deformity left, but that's not her concern. She's concerned more of the fat prominent when she smiles. So you can do that on a relatively older patient too, but in this case is a revision bleph. She had bleph before, and there's still prominent fat. Of course, I don't want to take out any more skin. She does already look like she had some lid retraction. So I took out the fat only transconjunctivally, and she's pretty happy about the results. Of course, you don't want to do fat excision only in these cases, right? You can see the patient has pretty remarkable tear trough deformity. If you just do fat excision alone, it does help with the prominent fat, but the tear trough is still going to remain. So in these cases, kind of similar to this patient, tear trough deformity, pretty prominent, some mid-cheek malar droop. So you're going to have to take care of that. So the fat is like the mound of the hill. The tear trough is the valley. So you want to kind of lower the mound of the hill, fill up the valley to make it more equal. Realize the orbicularis retaining ligament. So we're just gonna take a look at the video since we don't have a lot of time. You can see that I make the incisions similarly to what I showed you earlier. Use monopolar cautery to dissect all the way to the orbital rim. You can see here, that's the orbicularis retaining ligament that I show you here. You open that up all the way from medial to lateral. I usually prefer now, I used to do subperiosteal plane dissection, but now I prefer periosteal dissection plane because I can suture and bury my suture more easily. I go down all the way. Actually, this is like how I do mid-facelift kind of adjunctively at the same time. So my dissection plane goes all the way to the cheek. And then I develop the fat pedicle, open up the septum first, of course, and then develop a fat pedicle. Make sure I really release it from the inferior oblique. You can see the inferior oblique very nicely here, right? So I have had patients who had transient diplopia post-op. I never want to have that again. So I'd really make sure this step happens. And then I made the fat pedicle into like a nice flap. And then I buried the suture. This is a 5-0 vicryl suture that I use to suture the medial fat pad to the anterior orbital rim, a little bit below that. So I do this suture, quite a few of them, I would say, all the way towards lateral, sometimes, depending on how they look like. If they have lateral, tear trough deformity, I do that too. So this is what it should look like intraoperatively. And this is how you drape that over in that space. And then again, skin access trimmed out. You can see my immediate post-op results. This is at 3 months post-op, so it looks pretty nice. In some cases, I have to do transconjunctival transposition because the patient doesn't want any skin incision. In this case, we had a little bit of skin pinch, but you can see that her results also looks like her tear trough deformity improved. How do I transpose? for the fat transconjunctivally, there's two ways. You can have an external fixation or internal fixation. Nowadays, I only do internal fixation. It's a little bit more difficult. Let me show you. But I use a 4O Vicryl with a SH needle. Enter it through the skin first, and then pass it through the periosteal tissue. Make sure you really get that periosteum. And then I pull the tail inside to the wound. And then I pass that needle through the fat pedicle that I developed. And then I tie that inside, kind of shoved it into the cheek. So this is how I buried my suture, because a lot of my patients, they're cosmetic patients. They don't want to look like they have like a bolster right after the surgery. So this is how they look like. This is a revision case. She had a lower lid left done somewhere else and still bothered by the tear trough deformity. So overall, I just want to summarize, take home points. You just want to make sure you understand the patient issues and pick the right techniques for them, because not every technique works for everyone. I mean, one technique doesn't work for everyone, so you need to make sure you have the toolbox that you need. Thank you so much for your attention.
Thank you, Dr. Pinkman. Can I ask a question right now? Yeah. So, where you transpose the fat inside over the orbital rim, the first video which you had shown, you did not take out the suture through the skin, right?
I don't take sutures for the one that I buried. Is all absorbable.
So where do you tie it to? Like
to the periosteal tissue. So usually, that's why I said in the past, I used to do subperiosteal dissection. That's what I was taught. And then externalized the suture because there's nothing to tie to. Nowadays, I do periosteal dissection. So usually there's like muscle, right? Like the levator superioris, labia superioris here. So sometimes I even tie to the muscle if there's really nothing else that I can tie to. But usually I try to leave the periosteum so I can make sure.
So the fat is kept over the periosteum and tied to the pre-periosteal tissue.
Yes, correct.
And to the muscle above.
Yes, correct.
Okay, and the last video which you had shown, you took the suture through the skin.
So yes, so transconjunctival fat transposition, you have a lot less space to work with, right? Like compared to the transcutaneous approach. So it's like trying to tie everything in a tunnel. It's like a lot more difficult to go through the transconjunctival right away. So I pass the big needle through the skin into the pocket that we create, and then I pull the tail into, I make sure I pass through the periosteum, and then
during
pull
the first bite.
Yeah, and then I pull the tail out, and then I pass through the fat pad, and then I tie over the periosteum.
Okay,
yeah.
got it.
Yeah.
Very nice. Very nice recordings also, very explanatory session. Thank you so much.
So I take the pleasure of inviting Dr. Robert Goldberg, and he'll be speaking to us on temporal and endoscopic pro-lifting.
Bob has been a mentor to an entire generation of oculofacial plastic surgeons, and I don't think any of us are qualified enough to be introducing him. So very kind of Bob to join us, and I have a video from him which I'll be playing right now.
Who participated in putting this lecture together. But hopefully we can see you at a future meeting.
क्या हो रहा? ठीक है, करूँ?
Who participated in putting this lecture together, but hopefully we can see you at a future meeting. To characterize eyebrow lift, I suggest you really just think about three main differentiation features. First are the vectors. Now, we usually want some level of central vector in an eyebrow lift, although it always depends on how much redundancy there is in the glabellar area. And then generally we want a lateral vector, which can either be straight up, it can be in the direction, which I often like, from the lateral commissure of the mouth through the lateral canthus, or another vector is a circumferential vector, and I'll show you that with the endobrow, where we can actually lift in a vector that goes this way circumferentially, and that gets a nice lift of the midface area in here, and provides a nice lift of the lateral eyebrow fat pad as well. The next main characterization are the incisions. And so, the incisions can be variably above the eyebrow and the mid-forehead. We'll talk about some of the direct approaches. Hairline approaches can be very helpful also along the hairline. But in endobrow, the main incisions that I make are a chevron incision centrally, and then I like to make an oval incision temporally, and I'll show that to you a little bit more later. I personally don't find that much use in the paramedian incision that some people make, so I usually make 3 incisions, but some people like a 4th and a 5th paramedian incision. I find that if we get a good lateral lift on this vector and a good central lift on this vector, that those 3 incisions are generally enough. The final characterization is the plane. And the planes, whether we go deep below the facial nerve or subcutaneous above the facial nerve, are all based on the anatomy of the facial nerve. The most vulnerable places are here, midway between the tragus and the lateral canthus, and then to a lesser extent, the more distal facial branches, which run a centimeter or 2 above the orbital rim. It's important to remember the depth of the nerve. So here I'm making a line on the deep temporal fascia, which comes on over the muscle, and here's the superficial temporal fascia. The nerve runs between those 2 layers, so we either have to be safe, we have to be on the deep fascia, deep to the nerve, or we have to be in the subcutaneous plane, superficial to the nerve. Now, the direct eyebrow lifts take advantage of the subcutaneous plane, so we're working above the facial nerve. And these are very effective in elevating the eyebrow. The problem is that the scar centrally can really show up. So, we did a pretty good job of hiding it laterally, but in the medial brow, that suprabrow incision I just find is not very often cosmetically acceptable. But on the other hand, the lateral brow, so this is an incision that was made sort of in this position. The lateral brow, or the executive brow lift, that area heals pretty well, as you can see here, and that can be very effective, especially in a male patient. Same thing, just to get the tail of the brow up. And you can see the incision is really pretty minimally visible at 3 or 4 months. Another superficial dissection plane can be accomplished through a hairline incision. And there's a lot of value in this, especially temporally. We make the incision right at the hairline, and in fact, a trichophytic incision can be designed so that we bevel the incision and we have some of the hair follicles here in the flap. Then when we cut the distal part of the flap and bring the skin back, those hair follicles will grow through the incision. Here's the flap designed closed. And then here's the nice example of the type of temporal lift that we can achieve with that incision. And here's a patient who came back 15 years later. And you can see that that temporal incision has pretty much become invisible, and some of the hair has grown in front of the incision because of that trichophytic lift. The mid-forehead incisions aren't out of the question. In a male patient, there's no, with the receding hairline, there's not a great way to lift that medial eyebrow. And yet you can see he has a lot of heaviness in the glabella here. So he could really use that medial lift. So here I've made these 2 incisions in a horizontal line. Here he is, the first post-operative visit. And then perhaps 6 months later, you can see a little bit of a scar there. But it's not terrible. Most patients accept that pretty well. And of all the different options, it's not the worst for a mid-forehead lift, especially in a male patient. But here's a female patient. She comes in, maybe it looks like a month or 2 afterwards. There's still a little bit of redness in the scar. She likes to wear her hair in front of it a little bit. But again, in a patient that didn't have a lot of great options for all of this profound redundancy in the glabellar area and medial eyebrow, she gets a nice improvement. and that scar, I think, can often be acceptable. But the most acceptable procedure in terms of scarring is the endoscopic forehead lift, which completely hides the incisions in the hairline. Now, there was a time when we used to do an open coronal lift like this. I think the big advance in endobrow surgery was not avoiding that incision, although that was a tough incision to close and a tough incision to heal from. But it's the recognition that the eyebrow can be lifted on a periosteal plane with an adequate release. Everything is about the release. Here's where the brow is held up. There's this conjoined fascia along the temporal line that comes along the lateral rim and then all the way along the bottom of the arch. And then there's additional attachments along the orbital rim that I'll show you in a moment here. So here's in green, I've outlined that conjoined fascia along the border of the temporalis muscle. Then there's another attachment along the masseteric aponeurosis, which we release for a mid-face lift. But importantly, there's really strong attachments along the orbital rim, along the infraorbital rim here, along the inferior edge of the superior rim and along the inferior rim here. You've got to release those to allow the brow to come up. If you don't get that release, you're not going to accomplish anything with an endoscopic forehead lift. And I always point out this guitar string, which goes from the orbital rim to the zygomatic arch. Unless you release all of these tendons that I've shown in green, that guitar string will still hold the eyebrow down. Once all those periosteal attachments are released, the eyebrow flap is completely mobile, and the entire brow can be successfully lifted in the periosteal plane. I already mentioned the fact that we've got to be conscious of the anatomy of the facial nerve as it crosses the arch and as it crosses above the orbital rim. But if we stay deep on the periosteum here and on the deep temporal fascia here, we'll be safely plane. Now, the other nerves to be concerned about are the sensory nerves, the supratrochlear and particularly the supraorbital nerve. But you can see those very clearly with the endoscope and avoid damaging them just by being careful with the dissection along the orbital rim, as seen here with the endoscope rim and into the lateral orbit. I always insist that the fellows do a finger test. So here I'm in the operating room and I'm asking the fellow to put their finger in. When you've released all of those tendons, you should be able to completely sweep your finger from the zygomatic arch to the midline of the orbit, the way that I'm doing here, so that everything's entirely released, all of those tendons that I talked about. Fixation is the final step in the forehead lift, but fixation only controls the short-term result. The release controls the long-term result. And I've often said you should be able to fixate with a 5-0 vicral suture if you've released adequately. On the other hand, if you haven't done release, no amount of tugging on the flap is going to allow the brow to come up in the long run. There's a couple options for fixation. Some people still like a screw and staple. I find that patients hate these screws in their scalp, and I think there's a little bit more of a risk of alopecia from the tension on the screw and staple setup. There's the Endotine or the Ramesh screw, which is a newer device by Deepak Ramesh, our graduated fellow. All of these rely on some type of absorbable material that's put into the bone, and the flap is sutured to that. You can make a bone tunnel. Dr. Sykes made this device that actually is like a guide to make two tunnels that come together, and you can put a suture through the bone tunnels. So I think the easiest fixation is just with the suture. Henry Bayliss was our founding chief. He used to love suture fixation, and I've really taken to it myself. It's simple, inexpensive, adjustable, quick. This is the way that I do it. So I like to make, as I said earlier, a chevron incision centrally, 2 oval incisions temporally, sort of on the line from the corner of the mouth to the lateral canthus, right in that vector. I start with the circumferential incisions. So those are taken from the edge of the lateral incision into the subcutaneous tissue, brought with a long Keith needle into the central chevron incision. And as we tighten that, that gives us that circumferential lift of the eyebrow in that direction, brings up the entire midface and the tail of the brow. Then I like to make a central fixation suture that comes from the galea here up to the immobile scalp. And again, we can use Keith needles pushed under the skin And in this top one, we come out through the hole and in through the same hole, so the suture buries in the scalp tissue. And then we tie both of those in that chevron incision. That gets that central lift. And then finally, we can add a little bit of a safety temporal suture in this vector by suturing the superficial temporal parietal fascia to the deep fascia in the wound. And that gets this additional vector of lateral lift. So central, circumferential, and temporal vectors are all done with a single 2O PDS suture that has good longevity, eventually goes away very quick, very inexpensive. I teach the fellows the Goldberg principle that the lower side will always be lower, even if you do more release on that side. So if we see asymmetric eyebrow, I do more release down here in the glabella, taking out the corrugator muscle, taking out the elevator superciliaris here, and lifting the periosteum all the way along the orbital rim. And then laterally again, we get a complete release all the way along the lateral rim to the arch takeoff in the entire conjoint fascia. So I do very extensive release, more on the ptotic side. But even then, the low side is often still a little bit low. But we try our best to get symmetry in asymmetric cases and always focusing on that release, because it's the release that determines the result. We grade the surgery by the amount of release. Everybody's invited to Los Angeles in July. We have our annual aesthetic master's course. This combines a day of lecture with a day of cadaver. We do a lot of work with endoscopic forehead surgery. And when you leave here working with an international faculty and international attendees, we hope you would feel like a master. Course sells out pretty quickly, so if you're interested, you should check that out and make your application. So to summarize, eyebrow lift is about vectors, incisions, and planes. We talked about some of the different incisions, including the direct eyebrow, mid-forehead, hairline with the pretracheal incision, trichophytic, and endoscopic with incisions hidden in the hair. And importantly, we talked about the planes. For most of the cutaneous lifts, we're in a subcutaneous plane, which takes us
In the interest of time, over to you, Masashi.
Oh, thank you very much. I have one quick question. Which procedure do you prefer for the patient who has a very high hairline or without hair? That's the I want to ask the question to the all audience here.
You asking me that question?
Yeah.
That's always a tough one, because if someone's got a very high hairline, it's difficult to hide the incision no matter what you do.
Right.
So it's really a tough one. I would still prefer an endoscopic temporal brow lift because the incision will be much smaller as compared to the other mechanisms. What would you prefer in such a case?
Yeah, I think it's the same opinion because it's very hard to, hide the scars. So to minimize the scar length, so I prefer the endoscopic too. Yeah. Okay. And also, I want to ask the opinion about the. I'm sure there's some difference between the SNET because in the East Asian patient we don't have much of proptosis, but we have elevation of a brow. So we have less chance to do the endoscopic brow lift or some kinds of brow lift procedures. But do you find like in Thailand, do you prefer to do the same procedure like this or?
So I agree. I used to do endoscopic brow when I was a fellow in the US. And then for when I come back to Thailand, given my current job as an academic, position, it's a lot harder to do set a GA case for cosmetic. So a lot of times I just ended up doing other brow, surgery. And I would say most of the surgeons who perform endoscopic brow lift in Thailand are plastic surgeons that I know, yeah. I have tried to teach my fellows on selected cases, but there are very few,
Yeah.
because we didn't have time for OR.
Yeah, because I was in San Diego, which is California has 20% of East Asian population, and we found that there's very less chance to have brow ptosis patient in East Asian population. So I think there is something different between.
I think the tissue is a little bit different too, and I think it still varies among Asians.
Right.
I mean, even like Indians or East Asians or even Thai population, we have a variety of like minor ethnic group in Thailand too, and I think some of them have a very thick tissue, and to do endoscopic brow lift, I feel like the effect are not very long lasting. I feel like the endoscopic brow, in my limited experience, works better when patients have like pretty thin skin and not so much of a heavy face looking. Yeah, thank you.
I think Diva wanted to say something.
Dr. Pimkwa, I would like to ask you, like, which size of endoscope do you use during the endoscopic brow lift?
So I believe it's a pretty the similar one to the one we use for endonasal, but you just need the sleeve for the endoscopic, endobrow.
So like 4 millimeter we use for the adult and 2.7 millimeter for the pediatric endoscopic DCR.
Yeah,
So
you can do
is it the
adult one.
pediatric one? I believe it is supposed to
I
be
think
the
it
smaller
really
one?
depends on the size of the sleeve more than the size of the scope. So if there is a pediatric endobrow sleeve, then of course I think you can use the pediatric one, because I don't think the visualization is that much of a big deal in terms of the field of view. But I think it's more of the whatever sleeve they have. So you see it's more the adult size that they have for the sleeve. Depending on, I don't know what other company that you guys have, but we have stores.
Stores, So it's supposed to be 0 degree, 30 degree, or like
Usually,
something like that?
Usually you can use 0 degree. Might be easier.
Thank you.
You're welcome.
So Diva, in my opinion, initially when I started, the endoscope was used for visualization, especially because you were worried about the nerves and making sure that the nerves were not damaged. But then, like Dr. Goldberg spoke, you, after a point of time, get used to knowing that the nerves, you are going deeper to the nerve, especially if you're supraperiosteal. And as long as you don't harm the nerves which are then above you, you are fine. So visualization is not that much of a problem once you know the anatomy. So the change in my surgery occurred that initially the endoscope was the one to view things through. Then it became just a light pipe to make sure the light went in through that. After a point of time when I got the headlight in, that was responsible for that, and I realized I didn't even need the endoscope. So now in a temporal brow lift, we've got instruments, and I'll send you some photographs of those instruments, which have light pipes attached to it. So the elevator is actually a L-shaped instrument which has a light pipe attached, which allows you to visualize very beautifully well. You don't really need the endoscope, in my opinion. I've not used the endoscope, and we release it not only from here, we release it all the way right up till the vertex here. So the entire scalp is redraped. It's a type of surgery which we call an aesthetic lift. We actually trademarked and copyrighted that particular surgery. So everything from here till here is actually released. And you can do all that release very easily, do it blindly with an elevator without the necessity to see through an endoscope, in my opinion.
That's lovely. Thank you so much, sir.
You want to introduce Tanuj?
So our next speaker is Dr. Tanuj Nakra, who is a triple board certified facial and ophthalmic plastic surgeon based in Austin, Texas. And his topic for today's is non-surgical and surgical rhinoplasty.
Tanuj has been a great friend to us all for a long period of time, and it's such a pleasure to have him join us. He's in Austin pretty late now, waiting for any questions, so please let us know if you have any questions.
Hello. I'm so pleased to be with you here virtually today. Thank you so much for the kind introduction. And today I'll be speaking about a topic I'm very passionate about, which is rhinoplasty. As an ophthalmologist, I originally did my training in ophthalmology and oculoplastics at UCLA, and I did an additional fellowship in cosmetic surgery. So since that time, rhinoplasty has been an important part of my practice. I'm in Austin, Texas, and some of you have actually visited us here. It's a very vibrant city. We have conferences every few years in our practice, and we'd love to see you here in Austin. My group practice has been around since 1984. I'm privileged to practice with many other physicians, some of whom you know, including Dr. Jureraj and Dr. Bladen. And we're also part of the University of Texas at Austin Dell Medical School, where we serve as clinical faculty. Over the next 15 minutes or so, we'll be talking about the goals and anatomy of rhinoplasty, surgical approaches, and we'll be discussing both surgical and non-surgical aesthetic rejuvenation of the nose. Let's start out with goals. So the nose plays a very important part in the aesthetics of the face. As oculofacial plastic surgeons, we often focus on the eyes and the upper face, and the nose is a very integral part of the overall facial structure. There are various mathematical models that help us understand ideal proportions of the face, including the nose and how it fits within the face, specifically the 1/5 rule that tells us that the ideal nasal proportion should lie within the medial canthi of the nose, and also the vertical height of the nose, which between the base of the nose and between the brows should span 1/3 of the vertical height of the face. There are various other angles and anatomic landmarks that are important in the aesthetics of the nose, including the tip, the supratip break, the nasofrontal angle, and at the base of the nose, the columellar break, as well as the nasolabial angle. And importantly, the ratio of the length to the projection of the nose should be at a 1 to 2/3 ratio in an ideal proportion. Here's a patient of mine who underwent surgery to improve facial contour. You can see that she's got a wide lower face, relative mandible deficiency, and a wide nose that did not fit her face. We performed a buccal fat reduction, chin implant, and rhinoplasty to help achieve better proportion of a face. Let's now talk about the anatomy of rhinoplasty. So external anatomy is important, and when we're looking at the front of the nose, we certainly can look at important details, including the domes that define the tip. So when you look straight ahead at the nose, these are the two tip defining points that are indicative of the underlying cartilage structure. When we look at the profile of the nose, we again see the tip, the supratip break, and the transition towards the nasion and glabella. And at the base of the nose, we look at the proportion of the nasal sill and the alofacial groove. The internal anatomy mimics the external structures, and so we can see the tip defining points are formed by the most anterior projection locations of the lower lateral cartilages. Superior to this is the complex with the septal cartilage as well as the upper lateral cartilages that then smoothly transition to the nasal dorsum. When we look at the 45-degree angle, we can see the relationship between the lower lateral cartilages, which are shaped like ram's horns, that integrate and interdigitate with the upper lateral cartilages that overlie the septum and then transition to the nasal dorsum. The internal nasal valve is formed by the location of the upper lateral cartilage, and this is very important for a normal breathing function. The external nasal valve is formed by the external opening of the nose as formed by the alar contour. Let's take a look at the common surgical approaches we use in rhinoplasty. So two basic approaches. One is the open rhinoplasty, where we have a marginal incision inside each nostril that transitions into this inverted V or irregular stair-step incision. And there can be very similar approaches to avoid a scar. My preference is to use this inverted V approach. There are also sometimes cases where we can perform a closed rhinoplasty, where the incisions are made inside the nostrils alone. The most common approach, again, for me, is an external approach because we can visualize the cartilages and enhance and produce the best symmetric outcomes with an open approach. This marginal incision, as we delineated earlier, can be made in various formats. Oftentimes, most oftenly, it is placed along the inferior edge of the lower lateral cartilage, but depending on the goals of the surgery, the incision can be varied, again, to achieve different outcomes. For example, if we have to put a graft along the cartilage, we may decide to make an incision independent in the nasal mucosa from the cartilage to leave tissue behind to place a graft. Here are some views of that irregular inverted V incision and how we can connect the inverted columnar incision to the alar rim incision. As we expose the skin from the underlying cartilaginous envelope, the skin and muscle flap is lifted off, almost like opening up the hood of a car to be able to see the engine underneath. Once we lift off the skin and soft tissues, the deeper structures, the bone and cartilage, can be modified to achieve the goals of the surgery. One of the goals is to also achieve access to the septum, which can be used for building block materials. So we can harvest septal cartilage and utilize this for graft material during the rhinoplasty. Also, septal cartilage can be modified for the purposes of performing septoplasty during rhinoplasty. So 3 basic techniques are utilized in rhinoplasty to achieve the common cosmetic goals. The first is tip support. The second is dorsal bony contouring. And then the third is tip cartilage contouring. Tip support is generally...
We've just got about 4 minutes left. I'll pause Tanuj at this moment in time and open up to the panel for any questions or any other deliberations, because we're coming to the end of the course. Rhinoplasty takes years and years to learn. One video less or one video more is not really going to change anything out here. So let's just go right from Kaushambi and maybe a couple of comments before we move to the end of the panel.
Thank you so much for having me here. It was a very informative lecture. And I got to learn a lot new things. You know, being from a very basic, I've just completed my residency. So it was very nice and very informative. Thank you so much, sir.
So I'm Dr. Shilpa, and I think as in ophthalmology, as Dr. Debraj said, that facial cosmetic surgery session is happening in AIOS, that's a big thing, and I totally agree to it. Actually, the mindset of ophthalmologists have to change, that after ophthalmology, you can go to oculoplasty, and then you can do rhinoplasty also, which usually people think that it's an ENT surgeon's job. That's the main thing. And more such sessions happening in ophthalmic conferences are going to change finally this viewpoint. So, Dr. Debraj, thank you for taking the initiative. Dr. Diva.
This is Dr. Diva Ahmad from Nepal, and really thankful for this opportunity. And as always, Dr. Debraj said that the face belongs to whom? That's always a question. And we try to conquer as much as possible. Thank you so much.
So thanks for having me here. I'm Dr. Harika from Vijayawada. So I think this is one of its kind of course which is happening in AIOS for the first time. And maybe we'll be looking forward for bigger sessions each year, growing bigger and bigger. So this facial cosmetic surgery, I think ophthalmologists and oculoplasty surgeons have conquered it to most of the extent, and we'll be looking more in the near future. Thank you so much.
Hi, I'm Dr. Vishal Sharma from Dehradun, and I'm really glad to be part of this session, and very grateful to Dr. Debraj for having me here. One thing I would resonate with you all is that it's really that we all have come from a long way, and Dr. Debraj has led us aptly, and he's working too hard to create our presence into the facial aesthetic thing. and not just limit ourselves to the ophthalmic part.
Okay, thank you very much for this opportunity. My name is Masashi Mimura from Osaka, Japan. Firstly, I really thank to the Braj for including me in the session, and I really learned a lot, and also I wanted a lot about the rhinoplasty and your facelift as well, but maybe next time I want to do that too, and looking for the next session. Thank you.
Thank you, everyone. And ultimately, we become what we want to become. And the first changes occur in our own mind. And once we make the changes, then everything else falls in place. Thank you for being here at the beginning of Sunday. Thank you.
And at the last, I would like to invite you all for the OPI midterm conference holding at Missouri on 10th and 11th of May. The theme is on twists and turns in oculoplasty. So looking forward to see you all in Missouri. Thank you.
Missouri is a great place. In Vishal, we have an amazing organizing secretary. So if you're interested in oculoplastics, please be there.